Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me okay? Good morning to all of you. We're going to start this talk. Today is about the understanding the role of biologics in asthma care as a step towards more of personalized treatment in asthma patients. These are the...
We can't see you.
You can't hear me. Objectives, is it better?
Cross.
Objectives is we're going to go to the general guidelines, then we go through a definition of severe asthma, biology of severe asthma, and a bit about the phenotypes and the biological treatments. I know I'm limited to only 15 minutes, so I'll try to be as quick as possible. Severe asthma is a complex and heterogeneous disease of the airways. It's not like what we know in the past is only a single disease where all the patients will be treated with the same inhaler. So now the understanding is completely different. And in fact, in the last few years, we have also seen a significant development at the biology level, if you like, or the molecular biology level, and the treatment of severe asthma. Severe asthma is about 3 to 10% of all asthma patients, and usually these type of patients become refractory to standard asthma treatment, which is ICS LABA plus minus LAMA. This is the definition. So if we got someone who is already on ICS LABA, a high dose of ICS and LABA plus minus LAMA, and their asthma is not controlled, they're still getting exacerbations, they're still getting hospital admissions. These type of patients, they're not controlled. And even if they are controlled at step 5, but you are unable to step them down, then they also considered to be a severe asthma. You have to be very careful when you describe a severe asthma. Severe asthma is not a difficult asthma. So severe asthma is a patient who we know that he's taking his medications. He's very compliant with medications, good inhaler technique. We treated all the comorbidities like nasopharyngitis, chronic rhinosinusitis, or if they have a GERD, whatever comorbidities, we have treated them, but still asthma is not controlled. Only those groups are considered to be severe asthma. And this is the GINA guidelines. This is the common what we see, and what we always get concerned when we get to step 4 or step 5 treatments. So that's where we consider these type of patients are not improving, and we need to think about the next treatment. In the past, when we got a patient on high dose of ICS and LABA, we add LAMA, they're not getting better, we put them in the oral steroids. Oral steroids are not very good for patients on the short and long-term problems, including diabetes, hypertension, cautionoid. They get a lot of side effects. We don't want them in our severe asthma patients. This is it just shows you the evolution of understanding of severe asthma for the last 100 years. Initially, it's just a bronchospasm, then a bronchospasm and inflammations, and then we started to know more about the remodeling, and lately more about the molecular biology and the type 2 bronchial asthma. The biomarkers of severe asthma, the one the commonly we use is the serum IgE level, the serum eosinophil count, and the exhaled nitric oxide and the sputum eosinophils. Sputum eosinophils is mostly used for academic purposes and in tertiary centers, so we hardly use them in day-to-day clinical practice. So the commonest is allergic and eosinophilic asthma. They are the type 2 high asthma. In the next couple of slides, I'll tell you what's type 2 high asthma. And we also got the type 2 low asthma, which will be explained in the next couple of slides. This is a quick comparison. Allergic asthma is usually at a young age. They have a trigger, seasons most marked with them. they're less common to have a nasal polyps, and the severity of disease is not as severe in the eosinophilic asthma. They don't respond very well to steroids, the allergic asthma, compared to eosinophilic asthma. And they usually have a very strong family history of atopy or eczema. So this is the slide which shows to you how the biologics works. So when an allergen comes in contact with the respiratory epithelium, it triggers the production, if you like, of the alarms. And the most common alarms is the TSLB, thymic stromal lymphopoietin, and interleukin 25 and the interleukin 33. The allergen will be taken up by dendritic cells and presented to a naive THO cells, which activates the Th2 cells. That's where the terminology comes on. And then that will lead to production of all the interleukins, including interleukin 4, interleukin 13, interleukin 5. As you see here in the screen, the Th2 cells leads to production of all these interleukins. And from the interleukin 4 and 15, the interleukin 5 will work mostly in the eosinophils with the activation, maturation, migrations, and the maturation of the eosinophils, and then will start the cascade of eosinophilic inflammation and the bronchospasm, where interleukin 13 and 4 works mostly on the mucus fiber secretions and the production of the IgEs, and leading to sensitization and production of mediators from mast cells, leading to the bronchus inflammation and the bronchospasm as well. This is a quick, really, differentiation between Th2 and Th2 high and Th2 low asthma. So as I explained, Th2 asthma, they usually very severe, have a high eosinophil count. They might have a bit of IgE atopic component, and they usually respond very well to steroids. These are the common biologics we have up to date. So the first one was introduced in 2005, and then nothing for about 10 years. In 2015, we started to have the anti-IL-5. So we got the mepolizumab and the benralizumab, and then we have the dupilumab, and lately was the tezepelumab, which is working as an anti-TSLB at the level of the respiratory epithelium. Omalizumab is a monoclonal antibodies that binds to the circulating IgA, and that then will block the whole process. The main landmark studies is the INNOVATE and the EXTRA trials, which demonstrates that omalizumab significantly reduced asthma exacerbations and improved asthma control in patients with moderate to severe asthma. So in summary, omalizumab reduces asthma symptoms, reduces exacerbations, allow us to wean off steroids, but is not a very good drug in improving the FEV1 or lung function. The next group of biologics is the ones that works on the eosinophils, which causing eosinophilic depletion by the monoclonal antibodies. So we got two ways. One way is to get monoclonal antibodies that will bind to the interleukin 5 and prevents it from fitting to its receptor in the eosinophils, which is the mepolizumab or ristlizumab. The ristlizumab is the IV, so we don't use it. We got the mepolizumab, which we commonly use. And then we got another one called the benralizumab, which binds to the receptor, goes straight away to the receptor of the eosinophils and blocks the receptors and cause complete destruction or depletion of the eosinophils. Two ways, either to block the receptors and also recruit the natural killer cells, and that will lead to production of antibodies that cause apoptosis and complete destruction of the eosinophils. So the landmarks of this for the mepolizumab is called the DREAM trial, which demonstrates a significant reduced exacerbations in patients with severe asthma. The next study is the recent study, which UAE was part of it, is a multi-country observational cohort study. It shows that 76% reduction in clinically significant exacerbations. And also improvement in the lung function and asthma control, with about 1/3 of the patients be completely managed to stop steroids. This is the slide shows that the mepolizumab significantly reduced the rate of clinically significant exacerbation by 64%, and also reduced the rate of exacerbation for severe asthma required hospital admissions by 69%. Mepolizumab also works in because it's eosinophilic asthma with some IgE atopic component. This slide shows the evidence that the mepolizumab can work in patients with high eosinophils plus high IgEs, irrespective of how high is the IgE. If you see that, in this slide, mostly the favors the mepolizumab on placebo. When we come to talk about the benralizumab, this is the drug which causes direct or complete depletion of the eosinophils. Multiple studies, including the main studies were Sirocco and Kalima studies, and shows significant reduction in exacerbations, good asthma control, and improvement in FEV1. The benralizumab has also showed an evidence in reducing and discontinuing, so stopping oral steroids in severe asthma patients. Safety is very safe drug over the last 5 years, as shown in the Multi-ME study. And lately, I'm sure you have been hearing about the clinical remissions in bronchial asthma, and benralizumab shows about 60% of patients, they achieve the 4 component of clinical remission, which is no exacerbation, no oral steroids, improvement in the lung function, and improvement in the symptoms over 12 months. People might be concerned about the depletion of eosinophils, but the extended studies, it shows that there is no any safety signals from a long-term depletion by eosinophils by benralizumab, and it also showed that at least 75% of patients taking benralizumab were exacerbation-free every year. So they maintained the exacerbations over the years. If we come to the next pathway, which is the anti-IL-4, anti-IL-13 pathway, so the dupilumab blocks the receptor, the interleukin-4 receptor alpha subunit, and interleukin-13. So that will leads to down-regulation of the IgE production, eosinophilic recruitment, and mucus hypersecretions. The main study is the Liberty asthma Quest trial, which demonstrates significantly reduction in exacerbation by 67%, improvement in the lung function, and also improvement in the asthma control. It also showed that the dupilumab was very effective, or the efficacy is very high in those patients with the high FeNO, high eosinophils, or atopic features. The peripheral blood eosinophils and the FeNO are very effective biomarkers to monitor in patients on dupilumab. This is just to show you that the dupilumab significantly improved the FEV1, as you see in the graph there. Is a very early separation of the graph by the week 2 of randomization. So it's a really good improvement in FEV1 straight away from the starting of treatments. The best patients who dupilumab works on them are the patients with eosinophils of more than 100 to 150 and FeNO of less than of more than 25. So dupilumab shows a significant, also showed a significant reduction in exacerbations, in severe exacerbations, and also in exacerbations requiring the admission. So about 46% reduction in exacerbation compared to placebo. This study just really reiterate what we have already said, that shows the adjusted annual rate of severe asthma exacerbation by eosinophil and FeNO groups. So it really works across the board of all the patients with high eosinophils and high FeNO, but the best reduction rate on exacerbations was seen in the patients with FeNO of more than 25 and the eosinophil count of more than 150. I just got a couple of slides, if you could allow me. Coming to the last one is the tezepelumab. Tezepelumab works high up in the cascade and blocks all the interleukins, interleukin 4, 13, 5, and mast cells, and causes a significant reduction in exacerbations across all the, so in patients with severe exacerbation, also severe exacerbation requiring hospitalization. And because it works high up in the cascade in the upstream, it's very effective in both high T2 and low T2 asthma. So if you got a patient with low biomarkers, the only medications which is now indicated for low T2 is tezepelumab. And this is just a summary of all the biologics we have at the moment in severe asthma, and I'm happy to take any questions. Thank you very much for listening.
Thank you.